Good morning, everybody. Thanks once again for having me on the webinar. This is an exciting event, and I'm really happy that we're starting to mobilize action around these topics. So today, I plan to talk with you about migration, health, and information communication technologies. Soraya, thank you. All right, so today we are going to look at who and what is concerned when we talk about migrant health and information communication technologies. We're going to look at some strategies. I'm going to speak with you a little bit about our project, Caribbean Migrations, and talk about some lessons learned along the way. So, to begin with, some key definitions are important. First of all, speaking about equity, it's important to keep in mind that equity does not equal equality. So when we're speaking about equity and we're thinking about the most vulnerable migrant groups, we're not interested in sameness. We're not interested in having these migrant groups look the same as other groups within society. The goal with equity-based research and equity-based interventions is really the elimination of unfair and unavoidable circumstances that deprive human beings of their rights to education, their rights to health, their rights to other opportunities. And framing an understanding of migrant health in this way draws not exclusively, but a lot from the WHO, the World Health Organization, Social Determinants of Health framework. The focus here is on reaching the poor and the most marginalized in societies, and we're concerned with the specific context of inequity. So these contexts of inequity look very different depending upon where you are located. And so we're really concerned with locally specific equity stratifiers in these types of conversations. Now, bringing together two very distinct bodies of work, migration and health, is one feat in itself. But combining bodies of work on migration and health and information communication technologies is really a mammoth undertaking for which there's very little research currently existing. Just to give a little bit of background and a key definition in terms of information communication technologies, one of the foundational concepts in this area is the notion of telehealth. And that is concerned with innovations such as telemedicine, e-health, m-health. So many of these in the literature have disputing types of definitions. We're not going to get caught up in the semantics of the definitions. Right now, we really are concerned about the effective use of information and communication technologies for health. That's the definition of information communication technologies that we're going to be using here today. So thinking about migrants as a vulnerable group, one of the key questions that's guiding today's discussion is which health conditions make migrants a vulnerable group? When are migrants a vulnerable group? The simple answer to that question, it can be stated as always and all. So when we think about migrants, any migrant, depending upon the locally specific equity stratifier that is of concern, can be a member of a potentially vulnerable group. However, there are some key ways in which we can think about this as well. We can think about it in terms of health conditions, and we can also think about it in terms of the groups that are most vulnerable. So when we think about health conditions, there's an extensive body of work that suggests that migrants, when compared to non-migrants, show particular vulnerability in terms of their disadvantaged risk factor profiles. We see this particularly with specific types of health outcomes. So hypertension, chronic conditions, and obesity are some of these key health outcomes for which we see this disadvantaged risk factor profile and disadvantaged health outcomes. We see less vulnerability in general for cardiovascular and mental health outcomes. Now, this is not to say that migrants do not demonstrate at any point in time a lack of vulnerability or a poorer health outcomes when compared to non-migrant groups for cardiovascular and mental health. It's just indicating in a global way when we compare migrants and non-migrants, we see these different outcomes. And when we think about the groups that are most vulnerable, at any phase of the migratory process, whether it's pre-departure, travel, whether it's living or residing or working in the host community, or in terms of return, multiple groups can be considered most vulnerable. Refugees or deported persons, migrants who are really crisis-driven in terms of their being displaced internally within a country. So this could be because of natural disasters, political crises. Also vulnerable are migrants who are temporary migrants, seasonal migrants, serial or circular migrants. And these people are vulnerable because they don't really have access to standard systems, standard health systems, or standard health resources. And as is well known and well established in a large body of literature, irregular migrants, or people who have gone past their legal status within any type of host community, these are a particularly vulnerable group because they are legally restricted from particular resources. Older persons and children, so at either end of the life spectrum, can also be considered as particularly vulnerable, as are those facing language barriers and those with poor health literacy. So thinking about groups that are most vulnerable really requires us to think and ask ourselves, who is marginalized? And when we think about who is marginalized, a key question is who is invisible. And often our research and our programs, our interventions, and our policies are really fundamentally guided by who we can see, who is visible. And so we really have to do some hard work to try to understand who we are not accessing, who we're not seeing in terms of our programming. This can get at, for example, placeless populations. So moving on to another of the key questions for today in terms of which health-related situations can be addressed through information communication technology. We see from existing work by the WHO Global Observatory for eHealth that a broad spectrum of health-related situations can be addressed. So these range, as the example from the Brazil country profile illustrates, these range from macro-level health situations dealing with health systems to micro-level health situations which deal with individual-level interventions, behavior-level interventions, education-level interventions, and training, for example. So the broad spectrum of health-related situations can be addressed through information communication technologies. How have information communication technologies contributed to migrant health? In two distinct ways. On the one hand, they have actually contributed to inequities that face migrant populations. And on the other hand, they've actually been very useful in terms of facilitating equity for this population, these populations. In terms of inequity, we see that information communication technologies have actually facilitated, unfortunately, compromised message transmission security. So specifically thinking about health records, information that is really private, confidential, can be used negatively or against migrants, whether they are in their host countries or whether they have returned from where they originate. And they've also contributed to inequity in terms of ineffective data storage, security, and health information systems that are oriented towards normative clients. So health information systems that fail to take into account these invisible populations. They've also contributed to inequity in terms of their acting as avenues for the transmission of xenophobic and discriminatory sentiments. On the other hand, there have been some very promising interventions and policies that show that ICTs have actually contributed to equity for migrant health and equity in migrant health. So some of the most frequent initiatives that have been successful are health call centers, emergency toll-free services, and mobile telemedicine, for example. Although less frequently used, we also see equity being promoted through health surveys, health surveillance, awareness raising, and decision support systems. So now I'm going to speak with you a little bit about Caribbean migration. This is an innovative program of research, action, advocacy, policy that many collaborators and myself have been undertaking. And we can think about Caribbean migrations. The website is, as the name says, it's CaribbeanMigrationsPlural.com. And when you go to the website, you'll see that Caribbean migrations is really, what we're trying to do with this is to develop an innovative research and development organization that is focused on the Caribbean and the Caribbean diaspora. It's intended to conduct and facilitate programs of research to generate evidence-based interventions, advocacy, and policy for the Caribbean and the Caribbean diaspora. So our initial work with this vision in mind was to conceptualize Caribbean migrations and to brand it, and then to build a team that would help to execute all the different components of this larger project. We have used information communication technologies in a variety of ways. As you were probably got a sense of a little while ago when I directed you to the website, one of the major ways in which we have used information communication technologies is the development of a website. We are using this website to frame our work and our vision. We're also hoping to use it as a portal for our other social media outlets and for dissemination of research information, dissemination for other health-related information. We hope to use it as well for data collection. We had hoped, when we had initially started up the process, but this is also part of our lessons learned, we had hoped to initially conduct an electronic data collection. However, as we find out when we're on the ground doing work in resource-poor contexts, such as the Caribbean, it's often very challenging and it takes a lot longer to do things than we anticipate. So one of our first initiatives was a foundational research study. This foundational research study is called the Jamaica Return Migrant Study. The Jamaica Return Migrant Study was a sample, a small pilot study of a sample of 470 voluntary return migrants and 171 persons in Jamaica who had no international migration history. Of our sample, 71% could be considered transient migrants, 22% circular migrants, and about 3% are persons who have settled outside of the Caribbean region and have actually returned. And what we've found when we've done some preliminary data analyses, we're still doing our initial data analyses, we found that there's a lot to be learned about exposures to and opportunities with information communication technologies in terms of the voluntary return migrant sample and how it is similar or different from the no international migration history sample. So for example, of the persons who had a migration history, those who had regular access to the internet were more likely to have reported migrating at a younger age. So we see with this one example that exposures to other contexts, exposures to contexts outside of the Caribbean region may in fact be linked to, be associated with access and exposure to information communication technologies. This is particularly the case when you have persons who are migrating, for example, on seasonal work visas. Another illustration from the data thus far from the preliminary analyses is the variations in terms of health literacy and general education background. So when we went into the field, an interesting example is that we were using the word migration and asking persons about whether or not they had any migration history. This proved to be a bit problematic because the populations that we were accessing really didn't use the word migration when they thought about their travel experiences. So we had to adjust and ask them if they had ever traveled abroad, for example. This might seem like a small, insignificant detail, but it really speaks to matching your research data collections, matching your interventions with the population that you are targeting. And for us, it was really a lesson learned in terms of bridging this gap between researchers and data collectors and the persons who are on the ground in whom we're really interested. So as we wrap up, because I know it's a very, very brief talk today, I just wanted to reiterate that the goal for us with Caribbean migrations, with the Jamaica Return Migrant Study, with other studies that were undertaken, the goal for anyone who is passionate about, interested in the bridging of the migration, health, and information communication technology world. The goal should be migrant health equity that is facilitated by coordinated, integrated, evidence-based information communication technology systems and initiatives. To accomplish this, innovation is definitely necessary, and innovation can occur in any way. For example, one of the innovations with our Jamaica Return Migrant Study was that we partnered with the Mona Geoinformatics Institute to attempt to use GPS systems to locate the addresses of the persons that we were interviewing in deep rural communities. So innovation is necessary. We can also harness the skills and potentials of our youth and people in our societies who can think very creatively about how and when to integrate technologies with the research and interventions that we're planning. On the other hand, there is no need to reinvent the wheel because several countries and several communities have already started to engage with the bridging of these various bodies of work, research, action, and policy. And so what we really need to do is to find out what exists and to try to see to what extent those things are transferable to the communities in which we're interested. For this, collaborations and partnerships are essential because one thing that we have definitely learned with Caribbean migrations is that we can't make this journey alone, and there are many things for which our vision requires real unity in terms of partnerships. So there's also a need for locally specific but universally comparable approaches. And one example of this is that we can attempt to integrate Latin American and Caribbean information communication technologies, e-health interventions, m-health interventions with the WHO Global Observatory for e-health and see what standards are being established so that when we do the very important work of trying to design our monitoring and evaluation systems to go alongside our interventions, we're doing that not only with locally specific conditions and variables and factors in mind, but also in an attempt to demonstrate the utility and the transferability of these interventions, policies, practices that we're proposing. And very important, simple but true, we really have to be patient with this. The journey for us with Caribbean migrations has been, it's relatively young, but what we have found out is that it requires an incredible amount of patience and trial and error. So as one of my favorite poets and authors says, mistakes are the portals of self-discovery. So I think this should be one of our mantras as we move ahead in trying to synthesize these bodies of work and intervention. I would love to acknowledge my project team, the website development team, the Mona Geoinformatics Institute, and the funders. This project could not continue, because it still continues, without Vanessa Paisley-Clare, without Tiffany Palmer. The data collection could not have continued without our field staff, and most definitely none of this could be possible without our funders, the University of the West Indies Mona, the Society for Community Research and Action, and the Institute for Social Research. And a special thanks to our website development team as well, Ryan Smith and Ryan Strong. Thank you.
Thank you very much, Dr. Govia, for that excellent presentation. I think it was